That's very near and dear to me, and something that I think is a topic that many emergency doctors should be learning about. So the objectives today, just for 20 minutes, is to basically introduce you to the just very basics of regional nerve blocks, and then to talk about a brand new block which is used often, or can be used often for something that we see quite often in the emerge, and that's acute back pain. So for the usual case, you've got this guy that comes to your emerge with severe acute right-sided lower back pain after lifting a heavy object. He's in agony, he can't get off his stretcher. You prescribe your usual cocktail of Tylenol and NSAIDs and narcotics. It's either PO or IM or IV or what have you. But nothing works. He's still in agony, he can't move. And you ended up having to admit him to short stay because you just can't keep him in the emerge. And you hope that eventually his pain gets better. But this now could be avoided with a simple nerve block, which I hope to teach you about and explain to you about. So just some very basic things about ultrasound guided regional nerve blocks. I think this should be learned, at least a few of these should be learned by all emergency physicians. And the research out there show some very important patient-oriented benefits, such as better pain control. There are, of course, fewer complications. You can have these patients be discharged from your emerge much quicker. And then, of course, you have a decreased use of narcotics, which is always an important patient-oriented outcome that I think is important for everybody. So some basics of regional nerve blocks. What do nerves look like? Well, we all know what vessels look like and what muscle and all the organs look like. Well, nerves look like a honeycomb appearing structure in the body. It's very echogenic and actually follows a very regular course in the body when you're trying to find them. And when you're imaging nerves, contrary to what we've been teaching you for years about almost everything else, where you have to be very careful and very slow, I actually think that you should be more purposeful and active in your probe movement to locate and identify your nerve. So for example, here, you're not sure where the nerve, this honeycomb appearing structure might be, but clearly as I'm moving up and down this patient's arm, you can see there is one honeycomb appearing structure that just appears to be relatively consistent in its location. And sure enough, that's the patient's median nerve. Same thing here with the lower leg. You can see as I'm scanning up and down the leg, there's this honeycomb appearing structure that appears relatively consistent, and that's the patient's popliteal sciatic nerve. So be a little bit more active and purposeful in your movements to identify your nerve structures. Now, this is a term that is extraordinarily important when you are identifying and finding your nerves, and that is called anisotropy. So nerves are seen at its brightest when the ultrasound probe hits it at exactly 90 degrees. So if there is any slight fan or sweep in one way or the other, that nerve will become much, much darker. So not only should you be moving up and down and sliding up and down the patient's body looking for the nerve, you should be also tilting very, very slightly to make sure you're able to identify the nerve very, very quickly. So for example, in this video or this image, I can see that there's some nerve structures here that are quite superficial, but see what happens when I slightly tilt the probe or fan the probe, they suddenly become very, very dark. So if you don't hit the nerve in a perfectly perpendicular way, you might lose and you might not see it. So make sure when you're sliding your probe, for example, up and down the arm, do it nice and purposely, you do some small adjustments so you make sure that you're able to hit the nerve at exactly 90 degrees where it's going to be at its brightest. Okay, some technical aspects of how to actually perform your nerve block. You can perform it in one of two planes, either in plane, which looks like on the left, and out of plane, which is seen on the right. And there are both aspects that have some advantages and disadvantages. When you do an in-plane block, this is where the needle passes along the long axis of your sound waves and your sound beam of your probe. And the benefit is that you will actually be able to see the needle track all the way through from the moment it enters the beam or the field of view all the way until you hit the structure you're looking for. So this is wonderful because technically you will be able to see the tip of their needle and your needle track all the way through. The disadvantage is that you have to make sure that your needle and your probe are exactly lined up so that you actually can see the track. The outer plane approach has some challenges because while it's easier to have the needle go through the beam of the probe, is that the beam size is only about 1 millimeter in width. So if you look at the picture on the right, that needle tip is seen on that image below as a small little dot. But if you continue to inject your needle without making some adjustments to your probe, that shaft will look exactly the same as it did when you saw the needle tip. And so on your screen, it'll look and appear exactly, and you've lost your needle tip, which is the single most important structure you need to see when you're doing a nerve block, is to always know where your needle tip is. So as a result, I think that if it's possible from an anatomical point of view, always use an in-plane approach when possible, because that way you're able to see the needle track and see where the needle tip is at all times. The next thing you should know is people always have this impression that you need to get your needle tip right up against the nerve and be able to inject around the nerve. Well, that's not quite true, because all nerves travel in either a neurovascular bundle or a nerve bundle within fascial layers and fascial planes. So as a result, you can actually target the fascia next to the nerve. As long as you inject the local anesthetic within that fascia, then the anesthetic will bathe and surround the nerve and provide you with a very good nerve block. So you don't actually have to have your needle right up against your nerve in order to be able to get a good block. One of the things that I've always, people always tell me that they want to do a nerve block, but it just takes too much time, is that there's so much equipment that you have to accumulate before you get your nerve block done. So what we have created at the Jewish is basically a nerve block kit. These were created first for femoral nerve blocks, but it's basically the same thing for all nerve blocks. This is a kit that's got all the equipment ready to go, and it's kept in a place in our Emerge where it's a grab and go kit. All you need to do is get your local anesthetic, your gloves, and your cleaner, and you're good to go and to do your block within minutes. So it's, I think, an important thing to create in all the emergency departments. Okay, and then lastly or finally, positioning of you and the patient and the machine is very, very important. This is one of the only or few times where I tell you to put the machine on the other side of the bed, because you want to have your head lined up with your needle and your probe and the screen. You don't want to be tilting or turning your head away from your needle so that in order to look at the screen. So make sure you put your screen on the other side so everything is lined up appropriately to do your block. And then finally, while we don't have really much time to talk about it, know about your anesthetics, know the doses you're going to use, know about the contraindications, and of course, know and understand the complications of some of your anesthetics. And that's a separate topic altogether. So let's go back to our case. So this guy is in our emergency department. He's got severe pain. You've tried some Tylenol and some Advil or even some Dilaudid, and it's just not getting any better. In fact, he's just getting drowsy, which you can't send him home because of that. But as soon as you try to wake him up, he just is in the agony. You can't have him move. So the erector spinae plane block. So this is a block that is brand new. It was actually only described about 4 years ago by anesthesiologists who were seeing ways to provide blocks for compression fractures and posterior rib fractures, as well as for surgery, for back surgery. So the common indications that you're seeing in the literature are, as I mentioned, for posterior rib fractures, for some compression fractures of the vertebra, and even it's been reported for severe pain for post-herpetic neuralgia and for burns. But in the last couple of years, sort of case reports have been coming out about the use of the ESP block for muscular low back pain. And having used it a few times in the Emerge, I can tell you without a doubt, this is almost a game changer for these cases where you just can't get them out of your hospital or your Emerge because they're in such severe pain. So this is basically a single injection fascial plane block. Now, what do I talk about, or what do I mean by a fascial plane block? There's two kinds of blocks that you can perform on your patients. If you're doing, for example, an ulnar nerve block for a boxer's fracture reduction, this is a small volume block of the nerve itself. And that way there's small volume because you don't have much to inject, and you're actually injecting right around the nerve, or the fascia right beside the nerve. A fascial plane block, which for those who have done femoral nerve blocks with us, or the fascia iliaca block, this is a large volume block where we're talking 20, 30 cc's of volume. And so it's important to understand that it's the volume of solution and not the concentration of your anesthetic that's really important. So when I say that the ESP block is a single injection fascial plane block, it means that we're talking about injecting a good amount of volume, 20 or 30 cc's, into a fascial plane, and it's not necessarily targeting a specific nerve. So in terms of anatomy, these are your erector spinae muscles. If you see, I don't know why I can't get my cursor to show you, but these are your erector spinae muscles. They're muscle groups that are right up against the back of the vertebral body. And you can imagine that these are these sort of muscles that are in spasm when they come in with severe back pain. And it's believed that the ESP block works by basically blocking the sensory nerves of the erector spinae muscles of the back on the side that the patient is presenting with such severe pain. Sorry, Robert, do you know if I can see if there are questions? I don't have them on my computer screen. If you could just explain to me how to get there.
There are no questions at the moment, but I'll
Okay, perfect. All right. So if we look a bit at the anatomy, just to remind everybody what we're targeting and where we're trying to inject. So that's the spinous process of your vertebral body. There's your lamina and your transverse process, a little bit, or the most lateral aspect. And then these are your erector spinae muscles. And what we're trying to target are the dorsal rami nerves that are coming out just beyond or just posterior to the transverse process. So the goal here is to basically stick your needle or inject your needle all the way up to the area just posterior to the transverse process. And you're going to be injecting your local anesthetic in a large volume and basically blocking the dorsal ramus. And as a result of blocking the dorsal ramus, those muscles that are being innervated will become anesthetized, causing the back pain relief. So how do you perform an ESP block? So in terms of which probe, this also basically depends on the body habitus of your patient. Obviously, if it's a relatively thin patient and you think that the transverse process will be within 4 centimeters, then by all means use the probe on the left, the high frequency probe, because your images are going to look much, much nicer. But many of the time, you're going to have a patient which is a little bit bigger, and you won't be able to access the transverse process using that probe. So you're stuck using the abdominal or the curved array probe. That being said, put it on a nerve setting for both of these probes so that you have the best chances of getting a good view of your anatomy. Put these patients, now again, these patients are in severe pain. So when you see on the internet about people being put prone, these patients usually can't move. So the best patients for these situations are to put them in the lateral decubitus position with their affected side up. Now, if you're asking what does that mean? Well, if you can figure out what side of their lower back pain is the primary site, choose that side. On rare occasions, you may have to do a bilateral block, but I have yet had to do that. Usually they will give you a one side is worse than the other, and that's the one that you should have up when they're lying lateral decubitus. And what you're going to do is basically put your probe in the midline like we would do for a lumbar puncture, and find your spinous process and slowly slide out, looking for the lamina, and all the way until you find your transverse process. And so what are these going to look like? Well, if your probe is right in the midline, you see your spinous process, you're going to see it very, very superficial, the white area that with shadowing. And here we see very at the top, there you go. So there's your spinous process and your spinous process below. So you know you're on the midline of this patient. And now it's time to just move slightly lateral to that. And we're talking literally, you know, centimeter or millimeters or centimeters at most. The next thing that you may see are the lamina, and the lamina are going to be sort of this has a sawtooth appearance on your screen. And here you see the lamina that looks like a sawtooth appearance with a little bit flatter edge. And you know that you have to keep moving a little bit more lateral. And finally, you'll see your facet joints sometimes, and then eventually your transverse process, which is going to be the very rounded area, which is going to be bright white with some shadowing behind it. And right in front of that, in the near field, are the erector spinae muscles. So let's give you a couple pictures and images here. Here's a patient that has the spinous processes here, here, and here. I'm using a curved array probe because of the patient's body. And as we slowly slide laterally, you're going to see the lamina coming up here in the sort of sawtooth appearance right here. And as I keep going a little bit more lateral, here are the transverse processes. Okay, and this is your target area because these are your erector spinae muscles, and that's where you're going to be injecting, just above there. Here's another image of a patient, and this is actually a patient that you won't see the lamina too clearly, but here are the spinous processes. And as I slide laterally, I don't really see the lamina, but these are the facets, and then boom, these nice rounded transverse process. And this is your target for your needle, because these are your erector spinae muscles to allow you to inject. And there are no vessels in this area, so it's a pretty safe injection to do. So what you're going to do is finally, once you have your transverse process in sight, you'll stabilize the probe, and then you're going to insert your spinal needle in plane from the head cranial towards the feet, so cranial caudal, aiming straight towards that transverse process that you've got in the middle of your screen. And you're basically going to advance your tip until you literally hit the bony structure of your transverse process. That's kind of your end point, and you know you've reached far enough with your needle. You're going to obviously aspirate to make sure that you're not going to aspirate any blood, and you'll inject 20 or 30 cc's of your analgesics. For us, it's going to be bupivacaine. And what you'll see is you will visualize the separation of your muscles from the posterior aspect of the transverse process. And you know you've got a good, you got a good block. So here's an example. So here we have a transverse process. Here are the erector spinae muscles. And you'll see that the user's the needle will come right down here and aim towards this L3 transverse process. And as a result, you see the needle track all the way through. A little bit too caudal. There you go. Now you're going to cranially. Now you're going to inject, and you're going to see about your fluid going inside that fascial plane. Now you could stop there if you really wanted to be fancy. You could actually start and target the transverse process in front, but you don't really need to. You can actually just inject that whole volume just in front of the transverse process that you're seeing. As long as you've got that volume that you've injected, and you see the spread of the local anesthetic, then you're good to go. All right, so as mentioned, the initial indications for this were to treat posterior rib fractures. So the technique is the same, but it's, you're going to be using it on thoracic transverse processes, and there's a few little caveats because there are lung tissue in the way. But you want to make sure that you don't inject directly into the lung. Yeah, Rob.
A couple of questions, Joel. The first.
Okay, I'm not sure. I don't have the questions there, but if you want to just call them out.
The first is from Mustafa. Does the technique work for sciatica?
Okay, the answer is no, and that's going to be one of the things I'm going to talk about, the sort of things where it doesn't work.
And then Christine Wise asks, seems like the handedness of the doctor would make it very difficult to do both sides if the painful side is always up and you have to inject craniocaudal.
The handedness meaning if you're left hand or right hand?
Yeah.
I suppose if you're not too ambidextrous, you can have, remember, this is a two-person technique, so you're not going to be someone else is going to be injecting the syringe while you're doing the approach with the needle. But I guess if you really have a hard time with your left hand, then you could go caudocranial but most of what is described is craniocaudal, but you can do both.
And then finally, Josh Ryan asks, what percent bupivacaine are described and what do you use at the JGH?
So it's easy. 20% of 0.25, sorry, 20 cc's of 0.25% bupivacaine. That basically limits the concern of any side effects that you've given the maximum dose. And remember, if you want to have more volume, you can always increase that and add 5 or 10 cc's of normal saline. Remember, it's a volume block rather than a specific concentration.
Okay, that's all the questions.
Okay, all right. So remember that the issue is that you must always visualize the tip at all times. This is probably the #1 reason why these blocks will fail, is that you haven't lined up your needle with your probe, and you lose your needle and you think, well, I think I know where it is, and you inject and it's not in the right spot. And as somebody just asked, this is not going to work for other causes of back pain, such as degenerative discs, herniated disc or chronic pain. This is really for that muscle strain back pain that patients come in and they're in muscle spasm, and that's the main cause of their back pain. So just a quick summarize. Regional nerve blocks in general, I really think have to become standard of practice for pain control and obviously for the procedures that you do in the emerge. The patient-oriented benefits are very, very significant. I mean, the mountains of literature on the lumbar puncture, the femoral nerve blocks are significant. This is a brand new block. There isn't any randomized controlled trials, but I kid you not, there have been these patients where I have done an ESP block on these patients, and within 30 minutes, they are out of their stretcher, walking, and they're discharged home, versus patients that are lingering in the emerge because they're either too doped up on narcotics or their pain is just not being relieved. This is a fantastic block that you should try, and it's a relatively safe block. So like I said, it provides rapid pain relief, and decreases length of stay, and you can avoid any short admissions, and of course decreases the use of inpatient and outpatient narcotics, which I think is something that is in the back of our heads all the time for some of these patients. So as with all procedures, you've got to do one first. Whether you fail the first time, that's fine, but you've got to practice these blocks. You've got to practice with somebody helping you out, or do it on your own. Like I said, there are no major structures in there. It's just muscle. And as long as you see your tip and you hit against the transverse process, you should be able to do this quite well. I would suggest that all of you guys look at the New York Society of Regional Anesthesia. It's an amazing online resource, amazing website for those that are really keen on nerve blocks. I would maybe subscribe to that, because the amount of educational material there is fantastic in terms of anatomy and technique and stuff like that. And that's it. Any questions?
There's a couple more.
Yeah.
Again, from Christine Myers, how long will the relief last? And did I miss how you decide exactly what level to inject?
So first question is, how long does it last? It will last at least as long as they are able to get up and leave the emergency department. I have yet to see any of these patients come back. My guess is that you get their pain relief under control enough that they are able to mobilize, get those muscles moving, and that you will supplement them with anti-inflammatories and Tylenol. But the good question is, once the bupivacaine runs out, what happens after that? These patients don't seem to come back, because it sounds like you've gotten them over that hump of severe pain. It's like a status migrainosus. You get them well enough to be able to go home. They don't necessarily come back because they're able to manage their pain with the standard medications. In terms of where you would block them, you usually block them at the level of where they are most tender. It's usually going to be the L3, L4, but when you examine, you palpate them, you will inject in the area that they're most tender. But remember, this is a plain block. So when you inject at the L3 level, enough volume will go to the L4 dorsal ramus or the L5 dorsal ramus, so that enough of that will be spread along all the dorsal rami to really knock off multiple levels.
There's another question, and I think
Yeah.
they're raising the question of how much there's perhaps an element of placebo here, because there are studies showing that trigger point injections provide relief. I've seen studies showing intradermal sterile water injections can provide relief. Do you know of any comparative studies?
No, there are 0 studies, comparative studies. In fact, the largest study that was to date until a few months ago were case reports out of Nanaimo in BC, where 8 patients were given these blocks and they all were sent home. So, I mean, yes, you raise a good point. How much of this is placebo? If any of the junior residents wants to do a research project for the next 3 to 4 years, I would love to do it because I already have a protocol in place to do a research project. But if they are getting discharged home, I think, and their pain is relieved, and I don't have to prescribe them that many narcotics, if any, I think that's the best outcome for everybody.
Are you aware if any of the case reports or case series have added a steroid to get a kind of prolonged effect?
No, it's all local anesthetic.
Okay. Christine Myers makes the point that sometimes it's kind of difficult to localize a tender point. Is that something you've encountered and have, just tried to pick a point which makes it?
I will pick the point if it's L3, L4, L5. I pick the transverse process that I see the most clearly, knowing that 20 to 30 cc's of my local will spread above and below, and I'm not very, very concerned. Again, this is not such a precise nerve block where you're within millimeters of your target. You've got a lot of volume to work with, and so I'm not at all. The spread will be quite important to go above and below your injection point. So just go where you see the transverse process it's most clearly.
Now we have a question from Monica Chemiani. More often than not, patients on most tender very low down in the iliolumbar verge area. Any specific challenges when blocking that low?
Well, that's probably why you should go cranial-caudal, because if you go caudal-cranial, you're going to start injecting into their sacrum. So yeah, just choose the transverse process that you see most clearly. And if you go cranial-caudal, you're going to be at an L3, L4 as you're injecting into an L5 transverse process. And hopefully, again, the volume will take care of the rest. Again, this is not a foolproof 100% effective procedure, but it certainly is worth trying if you think these people are not going to be going home for the next 12 hours, or you're going to be doping them up on narcotics.
Question from Becca. Any trends anecdotally where it is less likely to work or more likely? So perhaps.
So any what?
And anecdotally, have you had any areas where it's less likely to work versus more likely?
I think, as one of you just asked about sciatica, I don't think it's going to work with sciatica. It really is a patient who comes in with the heavy lifting, or I did something at work and I just, I can't move my right-sided lumbar back muscles are in agony. Those are the cases where it's going to work. Any kind of chronicity in their back pain, I don't think it's going to work. And I don't think it's really worth you spending the time on those cases, because I'm skeptical that those are going to be beneficial.
Okay. I think